it this one?
Yep.
Okay.
Yep.
Okay. All right. Thank you.
All right, everybody, we'll get started. Thanks so much for those of you who are in the room and those who are connected remotely. This is not the ideal way to do this kind of session because it's a small case-based discussion. It would have been better done with a whiteboard and a camera, but unfortunately, due to some very last-minute schedule changes that we're dealing with, we're going to do it this way, and hopefully it will be just as illuminating and enlightening. I got a lot of feedback from fellows saying that there was a real need to do some small case-based discussions in pulmonary medicine, which I thoroughly agree with. I think, with all of us dealing with the pandemic for well over a year, there's been a lot of pulmonary medicine that we've lost a bit of continuity with. And so we're going to be starting up these sessions a bit more regularly, but we won't be doing them at this time frame. But this is a first chance pass, if you will, at some of this information. And I hope you find it to be useful as you go back to seeing patients in clinic and in other pulmonary care. So there's a few educational objectives for this small group session. One is to review the definition and subtypes of pulmonary nodules. Two is to understand useful imaging characteristics that can help you with your medical decision-making when you're seeing these patients in clinic. And then also to review the Fleischner Society guidelines and their application to nodule follow-up. I'll give you a caveat. I have not looked at this in close detail in a little bit. So the Fleischner guidelines in particular may not be completely reflective of the most recent updates. So that's just a caveat there, but I'll make sure I correct things as we go along. So our case is of Mr. Davis. He's a 65-year-old gentleman with a past medical history of COPD with an FEV1 of 40% predicted. He also has coronary artery disease and diabetes, and he comes to clinic for evaluation of a 1.5 centimeter ground glass right upper lobe nodule, noted incidentally on a chest x-ray that was subsequently seen on CT scan obtained during a recent admission for pneumonia. There are no calcifications in this 1.5 centimeter nodule. His recent admission was prompted by a left lower lobe consolidation and symptoms consistent with a bacterial pneumonia. In addition to the right upper lobe lesion and the left lower lobe consolidation, his CAT scan showed mild emphysema. So during his hospitalization, he was treated with 7 days of levofloxacin for community-acquired pneumonia, though we probably wouldn't do that, but he recovered without complication and is now back to his baseline respiratory status. He was told to follow up with you, a pulmonologist, for this CT abnormality to discuss his next steps in management. His last imaging chest x-ray was about 13 years ago when he was 52, and that was during an ER visit for chest pain, and that x-ray was unremarkable. He is a former smoker with a 30-pack year history, and he quit smoking 6 years ago and has no family history of lung cancer. So he probably should have gotten CT scanning through lung cancer screening guidelines, but that's not the scope of this question. So we have a number of questions that we're going to go through to kind of help you do some medical decision making for this patient. So your first question is, how would you characterize this abnormality noted on CT scan? What are the criteria for a quote unquote solitary pulmonary nodule versus a lung mass? And what are the relevant subtypes of solitary pulmonary nodules? Anyone? That's what makes it hard to do it in this format.
And it would be a nodule that is not surrounded by any abnormal, findings, with the absence of atelectasis, pleural effusions, and lymph node.
Yeah, so the definition of a solitary pulmonary nodule is, as you mentioned, it's an area that's less than 3 centimeters, surrounded completely by parenchyma, right? And there's no other adenopathy, no pleural effusions, no atelectasis, nothing else accompanying it. Now, if it's greater than 3 centimeters, it's a mass, right? That's what we know, and that's the nomenclature we use for these patients. Now, how do you typically sort of describe nodules? There's a little bit of clues here.
The one described here, it's brown glass.
Right.
Solid.
Right. So solid, semi-solid, subsolid, ground glass, or part solid, I guess, depending on how semantic you want to get. So this is from what we know, this is sort of a subsolid, because it's ground glass, solitary pulmonary nodule. All right. So he asks you what this nodule may be, and more importantly, what's the differential diagnosis for a solitary pulmonary nodule? What do you imagine is going through his head? Yeah, you're worried about malignancy, right? So is this a primary malignancy, a primary bronchogenic carcinoma, or is this a metastasis from somewhere else, right? So that's probably the first thing you're thinking of. What other things do you think of? Yeah, I heard something. So some benign things. What kind of benign things? Carcinoid? Yeah, or benign neoplasms, hamartomas, things of that nature. What about infectious stuff? Granulomatous disease, yep. And when you think of granulomas, what kind of stuff do you think of? TB. We're dealing with that currently. TB or non-tuberculous mycobacteria or other fungal infections. That's always on your differential diagnosis with granulomatous disease, right? Any other infections you think about? I mean, remember, this gentleman had a left lower lobe pneumonia. So maybe, lung abscess, maybe. Other more unusual things, AVMs, but obviously you don't have any description from his CAT scan that he has any vascular abnormalities. You think of congenital things, bronchogenic cysts, although the fact that he had a chest x-ray 13 years ago that was normal kind of knocks that off of your differential diagnosis. Anything else? Autoimmune, absolutely. Like what? Vasculitides, yep. Any in particular? Yes, I heard it. Granulomatous with polyangiitis, formerly known as Wegener's, absolutely. Rheumatoid nodules, yeah. Sarcoid, right? Yeah, you all have a really good and comprehensive differential diagnosis. And probably, what about pulmonary nodule mimics? Things that can kind of look like a nodule but aren't really. Rounded atelectasis, that's probably the most obvious one that you'd see. So you'd start, categorizing in your head, going through that differential diagnosis, which helps you then inform your patient in terms of what you think may be going on. So you mentioned the possibility of cancer, and now Mr. Davis is pretty concerned. So he asks you if you can tell his risk of cancer based on what you're seeing on CT scan, and what's helpful in terms of determining that. So what things do you think about when you're seeing a patient with a lung nodule? Spiculation, yeah. So the type of nodule, the borders, are they smooth? Are they irregular, spiculated? Do they sort of look, the location? Yep. Anything else? Size of it, right? The greater the size, the increased risk that this is a malignancy that you're dealing with, right? Yeah, so the type of nodule, the attenuation of the nodule, is it part solid, ground glass? Um, does that make it? I'm sorry, what?
Calcified versus non-calcified.
Calcified versus non-calcified. Yeah, we'll talk a little bit more because there's some specific manifestations of calcification that will make you think more or less malignancy. Let's go back to size for a little bit. Is there a particular threshold where you start to get a bit more concerned that it may be malignant versus not? Any cutoffs you've seen in screening?
Also size changes or doubling in size.
So, right.
Stability of size.
Stability of size. I heard it over in the left side of the room. Say it again, Shraddha. What were you saying? Yes, 8 millimeters is an important threshold because that's usually the tipping point where the likelihood of malignancy actually increases, right? So that's always something to keep in mind, and that's why that number comes up over and over and over again in screening guidelines when we're assessing risk of our patient. Okay, so now you're thinking, 1.5 centimeters, clearly greater than 8 millimeters. It's subsolid because it's ground glass opacity, and it's in the right upper lobe. Starting to raise your index of suspicion that you may be onto something, that this really might be cancer. And so that's what you're going to be discussing with him in regards to that, right? So you decide, you know what, I'm going to see if Dr. Spazzarni's around, and you're going to go review the scan with him or Tom Song. And, they mentioned to you that they don't see any calcifications. So what does the presence or absence of calcifications do for you? How does that help or not? It doesn't necessarily indicate that you're dealing with something that's benign. The type. What kind of calcifications have you seen described?
So the popcorn ones are more benign.
Popcorn. Yep. Popcorn tends to be benign. Homogeneous or lamellar, those kind of smooth or laminated lamellar calcifications tend to be benign as well. The eccentric ones that tend to be worrisome. So that's what you're thinking, right? If you're a radiologist, so just, by the mere mention of the fact that there are no calcifications doesn't really help you. And so keep that in mind when you're actually reading imaging, because again, there are many things that initially were on your differential diagnosis, particularly the granulomatous diseases that you would expect to see calcifications if they've been there for a long period of time. That would sort of sway you along that diagnostic evaluation. But the absence of them, really doesn't change sort of what you're thinking in terms of your differential diagnosis. So you're now thinking sort of what your next steps are for him. And what are your current recommendations?
Calculate his risk in the Brooks model. And that would just stratify him and kind of guide our next steps. Or we can potentially go towards like getting a PET scan and seeing the activity and then use like the Mayo risk stratifier. But I think that if we go with the Brooks model, we potentially can have him placed at at least a moderate to high risk and then go from there.
Yeah. And, this one's that's exactly the rationale that you would do. You'd use a risk calculator module to kind of help you. And you've got a lot of clues here just by his history, his social history, right? He has at least a 30-pack year smoking history, which right then and there is going to put him at a relatively high risk. Right? And if this were a solitary pulmonary nodule that was solid, how you would follow up screening would be much different than what you're dealing with, which is a subsolid nodule, right? So, you know, at least the 2017 Fleischner guidelines would say, well, you know, it's greater than 8 millimeters. You could probably follow it up again in about 6 to 12 months. Because again, it's a subsolid, partially ground glass opacity. However, if it was completely solid, then you would either be thinking PET, right, which you mentioned, or tissue sampling. Or if the patient really didn't want to undergo that kind of advanced diagnostic workup, you could say, okay, we'll scan you in 3 months and see what happens here. But most people, I think, would go for tissue sampling.
Separate risk assessment for that type of smoking?
No, not at all. No, I don't think anybody. Yeah. Yeah. And it gets even more complicated when you think about vaping, right? I don't think we have enough history with it yet to be able to risk stratify it, to be quite honest. So again, here are the older guidelines, the 2017 guidelines. So if he had a solid 1.5 centimeter nodule, then a subsolid ground glass nodule, I think we already sort of talked about that, but here's kind of the process that you would follow. Hopefully you can see that really well. You're going to assess his risk, right? And so I gave you some PFT data, although I didn't give you what you really need, which is an FEV1. I only gave you a predicted value, 40% predicted, but you want to figure out, are they an appropriate surgical risk? Because if they are, then you're probably going to go down this pathway, right? So if he's low risk, your probability of cancer is high. So you're going to go, you know, straight to bronch, staging and diagnostic bronchoscopy, PET, and then go to surgery. You'll go down here to surgical resection. That's sort of the pathway that you would follow. Whereas if they were high risk for surgery, again, you would still go down the biopsy pathway, but rather than resection, you would probably go down the SBRT pathway. And then obviously, if they wound up having metastatic disease, everything on the surgical pathway is not appropriate, and you would get chemotherapy, chemoradiation. So that's sort of the thought process that you would be following, and more importantly, that you would be informing your patient as you're making some shared decision making on what the ultimate outcome will be. I don't know what your experiences have been in clinic thus far, but it's not uncommon that the minute you mention this may be a cancer, the next few questions out of your patient's mouth is, okay, how do we figure this out and what's happening after that, right? And so it becomes important to at least have some framework in your mind in terms of what diagnostic evaluation is appropriate and what may be after making that diagnosis, so that, again, you can help inform your patient and help them make the decision. And obviously, no one is going to have this readily available in their head. I mean, it's a lot of information that you already have and you already know. So being able to kind of, you know, review references and have a discussion with your faculty member always helps kind of cement that plan when you're going in to discuss it with your patient. So that is sort of his workup from that standpoint. So again, given his smoking history and how things look on imaging, you estimate his risk to be in the moderate to high range. Some clinicians might obtain a PET CT scan before intervention, given his comorbidities. When is PET scanning actually helpful, or potentially helpful, I should say? And what are the limitations of a PET? So remember the characteristics of this nodule, right? It's ground glass. Yeah, so infection, you know, so again, you had all those granulomatous things, and you had some inflammatory things in your differential as well. So some of those can show as hypermetabolic on PET, right? But certainly with a ground glass opacity, it may not be hypermetabolic, but that isn't necessarily reassuring, right? Because of the test characteristics of the PET. So yeah, we talked about false positives with infectious and inflammatory lesions as well. And you know, if the tumor is growing slowly, again, you're not going to see a whole lot of hypermetabolism. So you have to keep that in mind if you're thinking about PET scan, because again, that is what you'll be using to help inform your patient when those questions inevitably come up. Because they are very, very common, because your patient is trying to get as much information as they can to make the right decision for themselves. So if this was only part solid, sorry about this. What would be the recommended next steps in management? And I think we already talked about that in terms of CT follow-up, right? You would do sort of, if it's, I mean, it's obviously greater than 8 millimeters in diameter. So you do a chest CT in 3 months, then PET, and then biopsy or resection, depending on, again, what your patient wants to do at that point. And then our final question for this dialogue: can quantitative models be applied to determine the likelihood of malignancy? And certainly you all have already talked about that, and that is exactly right. There's a lot of web calculators that can help you with this. You know, the Brock cancer prediction model is probably one of the most common ones that we use. And it uses age, gender, family history of lung cancer, uses smoking history, presence of emphysema, all of these sort of predictors for the likelihood of malignancy, as well as imaging characteristics, you know, size, location, spiculation, calcification, the whole gamut. And you can sort of put all of that, and if you put all of the information that I gave you into that calculator, his risk of malignancy is about 18%. So it is not negligible, to say the least. And so in that regard, you would definitely want to go down that pathway of doing a further diagnostic evaluation. So those are all the questions that I have for this case. Any questions you all have? Let's see. So let's see if we can sort of tie it all together. So you've got an 85-year-old woman with end-stage renal failure on dialysis, ischemic cardiomyopathy with an EF of 25%. We've never seen these patients in clinic, right? Severe COPD with an FEV1 of 28% predicted, on 4 liters, home oxygen. I'm making it real easy for you guys. Who presents to your clinic for evaluation of a 2.5 centimeter lung nodule, solid lung nodule in the right upper lobe. I can see those gears turning already. Her functional status is poor, and she's only able to walk across the room before becoming short of breath. She comes to see you regarding next steps in evaluation of her nodule. What would you recommend? I guess I'd start with, what wouldn't you recommend? What's the most obvious thing? You know, yes. So looking at this, she is definitely not a surgical candidate, right? You want to assess her surgical risk. So, you know, right off the bat, even though it's a solitary pulmonary nodule, doing any kind of wedge resection is obviously not going to be in her future. What else could you consider, or how would you approach it?
Based on her without getting tissue diagnosis.
With all of her comorbidities, you don't want harder
So, so she's not a good candidate, right? You've assessed her risk. So she's already over here, right? You already know you're not going to do biopsy. So what are you left with? CT, maybe PET, if you really want to put yourself out on a limb. But, you know, your evaluation is very short in her, right? Because, again, her comorbidities, these other things that she is experiencing, end-stage renal disease, on dialysis, emphysema, 4 liters nasal cannula, all of these things are going to have major impact in terms of her overall mortality much more quickly than this presumed lung cancer. So you'll have a sort of minimally invasive and minimal diagnostic evaluation and or follow-up, or let me back up, minimal diagnostic follow-up and no invasive evaluation for this patient. And, you know, we've all seen these patients that come to our clinic, and we do exactly that. We kind of give them the guidance that they need to know why we're recommending certain degree of follow-up and why we're recommending no follow-up for some patients, or very limited follow-up evaluation. All right, so we are at the 30-minute mark. So hopefully this type of session was helpful. Again, I know it's difficult to do over Zoom, so we've got to figure out a different way. We'll probably do it Skype next time. I am working with the chiefs, so my hope is that we can start these sessions on Friday mornings when we don't have M&M and staff meetings and some other things. So again, we can get some dialogue around these cases, and more importantly, kind of get your minds back into pulmonary medicine, since I think we've all been so ICU focused for a very, very long time. So we'll be doing more of this. So I look forward to it, and I look forward to it being helpful for all of you. So thanks so much.
Thank you very much.
No problem. Not bad for a